Good evening. Nice to be with you again this evening. We did, as I told you earlier today, for those of you that were here, there's three ways that I can tell when I'm out of balance. If I don't have time for exercise or devotional life or sleep, something is going to, be problematic soon. And so today, of course, we were on California time. We just arrived Thursday, so we normally do 4 miles of mountain hiking in the morning in California, but we got 4 miles in over at the Bailey Lake area, Burleson, and there wasn't anyone on those bike trails, and those bike trails were really nice. So Eric and I walked those beautiful bike trails there. And by the time we got back to our car, it was exactly 4.0 miles. So we enjoyed that very much. A little more wind than what we're used to in Northern California, but in those bike trails, there wasn't any wind at all. And so it was very nice. Well, glad to be with you this evening. We will have time for questions and answers, so if you have some questions about what we're presenting, we'd like you to save those, and we'll be glad to try to ask those. There might be a roving microphone potentially at the end of this presentation. So, the amazing human brain. It's the most complicated structure ever investigated by science. It's comprised of 100 billion nerve cells, made up of thousands of different types of cells and over 100 trillion synapses or connections. So that makes even the national debt seem like kind of a small number in comparison to the amount of connections you have in your human brain. And when you add up the mitochondria, it's even more amazing, because the most mitochondrial dense areas of your body are in your brain. In fact, that's what makes up the gray matter. The gray matter is from all of those mitochondria that are producing that dense gray color of the brain. And brain diseases are actually due to mitochondrial or metabolic diseases of the brain. And there's a number of things that can affect the metabolism and the way those mitochondria are working. And so that's why every mental health case is a challenge to find out which are the precise causes that are bringing about this metabolic issue in regards to the brain. The brain can resiliently regenerate and rewire itself through a process called neuroplasticity. And this is the amazing thing about our brains, and that is they can change. They're not static. And they can actually change in a positive way throughout life, or they can change in a negative way as well. So you're not stuck with the brain you're born with. If we can harness the power of neuroplasticity, amazing positive changes can take place in a relatively short period of time. If you're not signed up to our Nedley Health site, I would encourage you. We'll have a little a booth here where you can sign up. I think it's this Wednesday or Thursday. I'm not sure which day. I'm having to speak. You know, sometimes when you're a speaker, you have some begrudging places to go, like Maui, Hawaii. And so we're headed to Maui on Wednesday, and we have to speak there on Thursday. But my son Nathan is wanting us to do a webinar. It's an important webinar. It'll be a 1-hour live webinar, so you guys can ask questions and answers as well. But we're going to be covering the 5 major myths in psychiatry. And a lot of these myths are believed by some doctors. Fortunately, the ones who understand the brain pretty well, the top psychiatrists, they won't be myths to them. But they are myths to a lot of people in humanity and even some doctors, so we'll be covering each of those myths in quite a bit of detail. But one of the sidelines of one of the myths is that my brain can't change. And of course, the brain can change if we have a frontal lobe. Now, there are some brains, the frontal lobe's been wiped out, like Phineas Gage's frontal lobe was wiped out with an accident, then we're limited in our ability to have that brain change. But if you have a frontal lobe and that frontal lobe is enhanced, the brain can be changed in very dramatic ways. It can learn, retain, and apply knowledge gained over a lifetime. Well, in our society today, despite the knowledge of the human brain, psychiatric illnesses are on the rise considerably. The CDC states the nation has the highest rates of mental illness since it's ever been tracked in the United States today. Rates are going up in children and adolescents and adults, but the highest rate increase is those under what age? 30. The age of 30. Now, we should have a lot more people under the age of 30 here today, but many of them are hooked to their devices that don't tell their brain how to get better. In fact, those devices could actually worsen their mental health considerably in regards to how it's commonly used. Which mental illnesses are rising? Depression has doubled in less than a decade. So rates of depression are skyrocketing. And by the way, when does depression tend to start occurring in children? Does anyone know what age it starts? It starts occurring. It's actually virtually unheard of in kids 5 and under. Now, anxiety can be in kids 5 and under. You can have anxiety at a very young age. In fact, someone was telling me before getting on the platform how their pet has anxiety. And so you can have anxiety without a frontal lobe, but in order to have depression, you actually have to have a frontal lobe. Now, an animal, for instance, their frontal lobe is not developed enough that even if they have a terrible day, a terrible life, they will never consider taking their own life. They could have just been run over by a car in tremendous pain, and they will never try to take their own life. But a human being who is thinking about taking their own life, it's a sign that they're able to reflect upon themselves. And so depression and suicidality does not start until about age 6. That's when the frontal lobe starts to develop enough to be able to reflect upon themselves. So when I see someone that comes to our program who is thinking suicidal thoughts, I know there's hope because I know they have a frontal lobe. They're reflecting upon themselves. Now, they're not reflecting upon themselves accurately, but they are reflecting upon themselves. And so I know that there is a great chance that we can change, that we can help that person change their brain. So ADHD, also going up. In fact, if you are raised in today's culture and you use devices the way pretty much everyone is taught to use them, you will end up with ADHD as a kid, even though you don't have a genetic disorder for it. Now, there is a genetic disorder for it called pyrrole disorder. When people come to our residential program, we'll look for any of these genetic mutations. In fact, maybe I should go ahead, speaking of that, let me see if I have it here. Maybe not. I will... Yeah, I don't have it here, but let me, I will get it here. I've got more than one presentation here, and let me pull up, here we go. This is going to touch on one of the myths as well, but this is a synapse. The area there where you're seeing most of those little green dots called serotonin. And by the way, serotonin is made by mitochondria. It takes over 1 million ATP molecules to make one serotonin. ATP is the energy portion of our neurons. And so it's making the serotonin, it's actually helping the serotonin move to the membrane if the mitochondria is working well. And then when it gets released, it can then be picked up by a nerve right next to it. That's the synapse. And once it binds on to that receptor, then electrical transmission occurs. And this is what produces you to be able to tolerate the usual nuisances of life without getting overly frustrated. It helps you to be able to not get panicked when you're under stress. Serotonin helps your mood to not go down when you're having things not go right for you that day. And so serotonin is an important molecule to help us. And of course, once that synapse occurs, notice that arrow. That arrow is showing that it's going to be vacuumed back up into that releasing neuron. It's going through the reuptake channel. And the reason why that reuptake channel is there is so serotonin can be used again, and you don't have to use another 1 million ATP to make a new one. And so many people, at first, when they start to experience mental challenges and they see the doctor, first thing that doctor is going to tend to do once they have those symptoms of depression is to do what? That's right. Put them on an antidepressant. Do those antidepressants help them to make more serotonin? No. Does it help them to build up more receptors? It doesn't help them to build up more receptors. So how is it working? Well, notice in that second column slide there, you have not serotonin being vacuumed back up there, but you have an antidepressant called the SSRI. It's trying to be vacuumed back up, but it can't get it all the way back up, and so it plugs that vacuum cleaner. The way these drugs work is they're plugging the vacuum cleaners for the neurotransmitter that they're designed to treat. Now, of course, the pharmaceutical company doesn't call them vacuum cleaner pluggers. They could. It would be accurate, but it might not sell as many drugs. So let's utilize a term that society's not going to really understand. Let's call them selective serotonin reuptake inhibitors. And so it plugs that channel. And since you don't have enough serotonin that was being made for whatever reason, and there can be a number of reasons why you're not making enough serotonin. By the way, a lot of people think if serotonin is that important for my brain, why doesn't the doctor bring me in and give me IV serotonin? Just put it in my veins. Get it in my brain. Now, the doctor could do that. They're actually, we can make serotonin in the laboratory. We can put it in IV bags, and we can infuse it. But will it help the patient? It won't help the patient at all. By the way, 95% of your serotonin is made in your gut. It's one of the reasons why I know about serotonin. I'm a GI doctor as well. And so serotonin is made in the gut, but it doesn't help your brain because it doesn't cross the blood-brain barrier. It's too large a molecule to get across. And so we have to have the manufacturing plant in the brain to be able to adequately have serotonin activity in our synaptic clefts. And so that means we need to have enough tryptophan. And it's not just tryptophan. If you eat tryptophan in turkey, they followed the tryptophan in turkey. There's a lot of tryptophan in turkey. It'll go into your gut. It'll go into your muscles. It will not go into your brain. Why? You need carbs with the tryptophan. You need certain B vitamins to go along with that tryptophan to be able to get to the next step of 5-hydroxytryptophan and then 5-hydroxytryptamine. You also need light. You need the right type of light. The best light to make serotonin is your 460 nanometer blue sky light, as you were seeing today. And as Erica and I were seeing today in that Burleson hike, our brains were able to make more serotonin. And the exercise was helping the receptor aspect of things. And it might be a genetic issue. There are those that have a gene that is a mutated gene called undermethylation. If you're not able to methylate, you can't make that final step to make serotonin very well. There's a major challenge there. And we don't fix that with drugs. Now, the drugs will actually, if someone is an undermethylator and they're put on SSRIs, they'll think, I guess I just had a Prozac deficiency. Because it's helping me. I'm getting more serotonin activity. Yes, you're getting more serotonin activity short term, but the serotonin's not being vacuumed up into the neuron. And so you're going to actually short the neuron of the very substance that drug was designed to treat. Dr. Whitaker from Temple University has aptly shown that the antidepressants will actually cause depression once you use them for over a year in someone who wasn't previously depressed, because it's plugging the uptake channels, and now the brain has to make more serotonin, and it had a mitochondrial defect to begin with. And so this is how psychiatric cripples come about, because then a year later they're relapsing and they're on the medicine. And now they need more medicine. And now the dosage increased. And now we have another medicine that's needed. And by the time a person comes to our program, often they're on 4 different antidepressant medicines, still severe depression, and no one has tried to figure out why weren't they making those neurotransmitters to begin with well enough? What's going on that those neurotransmitters aren't being made? And so that's when we have to get into looking at their metabolism and seeing what's going on there. So one of the myths, obviously, is that my brain biochemistry can be fixed with pharmaceuticals. Well, you can get some help. It's not that these medicines don't help. They can help in certain cases. Now, if you're an overmethylator, an SSRI won't help you at all. It'll make you worse within 3 days. And so often the doctor is saying, try this, try that. Well, this made me worse. And so it's this whole trial and error thing. Once we find out where the metabolic defect is, it's not try this and try that. We know this will work. And we know what caused the primary issue in the brain. And so biochemically, you actually can get fixed, but it's going to be through nutrients. It might be through nutrient supplementation. It might be through exercise and light and things like that. So let me go back to our original presentation here. Which mental illnesses are on the rise? Depression, ADHD. By the way, suicidality is off the charts today. 1 out of 10 teenagers attempted to take their life last year. 1 out of 10. Now, many of them did not even end up in the ER. If they injured themselves enough, they ended up in the ER. But there's about 3 or 4 times that amount that are considering doing it that haven't done it yet. And so we're seeing a marked rise in suicidality as well as depression. Anxiety rates have also more than doubled in 10 years. So we're seeing all sorts. Of course, anxiety is not just generalized anxiety disorder, it might be phobias. One of the phobias that's an all-time high in our young people is social phobias or social anxiety. We have people in every one of our programs, often they're university students, and they're coming to us from their university They go to the cafeteria to eat, they run back to their room, eat it in their room by themselves. They go to class, they don't want to associate, and they go back to their room. They're fearful of having social interactions or even being seen. Some of them have what's called social appearance anxiety. Social appearance anxiety is that you just know you're going to be judged negatively when someone views you. You can imagine how that can produce anxiety. And of course, it leads to eating disorders and those sorts of things. Bipolar disorder. 1% of the population had a bipolar disorder in the 1970s. Now it's 7%. Autism. 3 times increase since 2000. Schizophrenia is going up. And, these are considered biological genetic disorders, but why is that going up if it's just biological and genetic? Is the genetic mutation becoming that much more prevalent? No, it's not. But there are factors that will, if you have the genetic mutation, that will lead to schizophrenia. Let me tell you one that's pretty simple. One of the reasons why we're seeing schizophrenia rise considerably is that marijuana, if you have the gene for schizophrenia and you take your first marijuana, you are 12 times more likely to develop psychosis and schizophrenia. By the way, all these marijuana shops, they should be making that person pay $700 to see if they have the gene or not. Because if they have the gene and they use marijuana, it could ruin them for the rest of their life. Schizophrenia can also almost be a fate worse than death. And so we're seeing psychosis, schizophrenia, often marijuana-induced, drug-induced. Now, if it's just the first time and they come to our program, we can reverse that. We had a young man, sad case, young man that went into psychosis from his first marijuana use at age 18. And he came to our program, we got him better, no more psychosis, was rational thinking, and I told him, do not use marijuana again. Do not use marijuana again. He did well for a year, and then he got in a social environment where everyone was using marijuana, and he used it again. And now he was back in the psych institution again. Manic, hallucinations, the whole bit. And this is a dangerous drug. It's a dangerous drug, and it should not be allowed to be used by anyone who just wants to at a party. It is a pharmaceutical, but it's a pharmaceutical. Yes, some people are looking for the benefits of it, but it's a pharmaceutical that has significant risks. It'll take away your motivation for almost everything that's useful and healthy in society as well. And so our country's making a big mistake going the marijuana route. By the way, why are they doing that? It's the financial part. Because marijuana was illegal, and so if it's black market, then you can't tax it. And so let's make it legal, and now we can pay our teachers more money. And we'll be able to have all of this extra money for all of the goods and services, and the government won't be in the red anymore. Well, that hasn't worked out so well. And it turns out that all those things that were promised haven't happened because the expenses of taking care of the marijuana complications are far more than the tax dollars they draw in as a result of the marijuana. So very short-term thinking. And so once again, even in schizophrenia, we need to go to what is the root cause. Now, let me just tell you some good news about schizophrenia. There's also some very bad news. But the good news about schizophrenia is if we can find someone who is going psychotic in their first 6 months, we can reverse that process in our residential program by looking at the biological thing. But if it's been going on for years, we can help them, but we're not going to be able to get rid of the schizophrenia part. And so this is why it's very important at the earlier stages to try to get help. Substance use disorder, climbing dramatically. Other problems that are increasing, burnout. 67% feel burned out at least some time, even in their job. Deaths of despair are going up. What are deaths of despair? Deaths due to drug, like opioids, alcohol, and suicide-related deaths. Those have more than doubled, and that was the year 2009-2017. They're actually continuing to go up. And this, they've looked at it economically. This has nothing to do with economic status. Deaths of despair are occurring in wealthy people. It's occurring in people that are normally considered by Americans to be favored or privileged, but they're dying from deaths of despair. By the way, it's decreased longevity in this country. Our longevity has been going down as a result of the mental illness, not physical illness increasing in our society. It's going down because of that deaths of despair. So 1 out of every 4 people around the world, 2 billion people are living with a mental disorder, and it's, of course, more common in the United States. Over 1 in 3 adults have a diagnosable mental illness in any year. That is far worse than what it was when I grew up. Among adults, mental illnesses, again, very common, particularly in the 18 to 25-year-olds. These illnesses affect the ability to function and often adversely affect relationships. They are a strain on the family. They are going to decrease your employment ability because of your ability to function. They will decrease your ability to actually experience fulfillment. And out of all of those diagnoses, depression and anxiety are the most common diagnosable mental health disorders. We should cover what is major depression. The DSM criteria have stayed the same all the way through, and so it's not that we're measuring differently that it came up, but you have to experience 5 of 9 symptoms for the majority of the time for at least 2 weeks without any recent obvious emotional trauma. Now, if it's recent emotional trauma, it's still depression, but that's called situational depression, or in the psychiatric Bible, it's called an adjustment disorder with depressed mood, but it's still depression. So 1, deep sadness or emptiness. Men tend to get more of the emptiness, women the sadness, so they might get into crying spells, and that's one of the reasons why women are diagnosed more often, because women will go to the doctor when they start crying and they realize it's not like their dog died or anything like that, and they are asking the doctor, why am I crying? And so they'll go to the doctor and they'll get diagnosed, where no man ever goes to the doctor with a chief complaint as I feel empty. And I've never had it. I've been practicing medicine for decades. Never had a chief complaint of a male coming to my office saying, I'm here because I feel empty. And so they don't even recognize. Often when they're diagnosed with depression, they're saying, I'm not depressed. What does that mean? I'm not sad. But they could still have 6 or more of these 9 symptoms and actually be suffering from major depression as well as the consequences. Second, apathy or loss of interest. If you're waking up in the morning and you're not excited about the day, that's a sign that you have apathy. Now, that can happen once in a while to anyone, but when it happens on a regular basis, where you're getting up out of a sense of duty and responsibility but not interest, that most commonly is going to be depression. And then things that used to be enjoyable are no longer enjoyable. This normally has to do with dopamine activity, a different neurotransmitter. Being more irritable than you used to be, or just slowing down even mentally can be the third symptom. Sleep disturbance. Now, hypersomnia is one of the symptoms. We have people that have come to our program that are sleeping 20 hours a day. The last woman that came to us sleeping 20 hours a day, she was in her bed for 3 out of the 4 hours that she was awake, directing her family from her bed. And she was barely out of bed and awake long enough to be clean enough and to be able to eat enough to be able to survive. But unfortunately, after she came to our program, she's down to 8 hours a day of sleeping and getting a lot done and enjoying her life and being far more fulfilled. But you can have another sleep disturbance is you can't sleep, insomnia, but the most common sleep disturbance is what we call early morning awakening. This is where you're able to go to sleep, but then you wake up too early and can't get back to sleep. And any of those qualify as a sleep disturbance that would qualify for major depression. Weight or appetite changes. Which is more common, weight gain or weight loss? Well, I hear both. Weight gain actually is more common. Why is weight gain more common? Yes, it's called self-medicating with food. And what types of food do people self-medicate with? Yes, sugary foods, junk foods, high-fat foods. And these foods not only taste good and make you feel a little better short term, but they actually can transiently, the sugary foods can transiently increase your serotonin levels. If it's chocolate, it can transiently raise your dopamine levels. So you actually feel less depressed and you feel like, oh, maybe I can talk to somebody now. But a nadir starts happening shortly thereafter, and we'll never solve the obesity epidemic in our society till we solve the mental health issues behind it. And so it's very important. Interestingly, in our program, we'll have those that are overweight lose weight, and in the same program, those who had no appetite and are underweight will gain weight. We had a high school girl in our program recently, admitted to our program, 69 pounds. She was like 5'5". She had been in a hospital where they had been feeding her through an NG tube because of her anorexia and eating disorder. And she still couldn't gain weight after that, so they found our program and sent her here. And she was told in the anorexia program that she wasn't allowed to exercise. They were fearful that she would expend too much energy and just die because she didn't have enough, calories in her system. And she was surprised at the end of the visit. I said, I want you exercising 60 minutes a day. Really? She said. I can exercise? I said, yeah. She goes, that's great. I love to exercise. And she ended up, I got to the root of the issue, she ended up gaining 5 pounds in 10 days. And some of that was muscle mass as a result of the exercise. And so in the same program, the underweight will gain weight. Lack of focus or concentration. This is where you're reading a page, something you're interested in. You get to the bottom of the page and you realize you forgot what was at the top of the page. And then you have to go back and try to read it again. And maybe the second time through you realize you missed it again. Lack of focus and concentration. Fatigue, lack of energy. You run out of energy too early, or you wake up and you don't even have energy. Number 8 is feelings of worthlessness. We talked about that a little bit this morning. But people that feel worthless will be convinced that they are worthless. But yet anyone who has the ability to be of use to themselves or others is clearly not worthless. And they have the ability to be of use and of help to themselves and others. But they believe that they are completely worthless. They believe their families would be better off without them, etc. So there's irrational thinking that comes along with depression and anxiety. There's always irrational thoughts that when you dig deeply on the surface, they appear accurate to them. But they're just plain wrong. And twisted thinking, major cause of suffering. And then morbid thoughts. 8 and 9, if you have those, that's a sign of severity. This is where you're thinking about death a lot, or thinking that you might be better off dead, or resonating with symbols of death, or thinking you'd be better off if someone else died in your life. That's also a morbid thought, thinking your depression is just due to somebody else. So how many of these do you need to have? Just 5. 5 of 9, and you have major depression. If you have 2 of 9, it's considered minor depression. And so minor is 2, 3, or 4. And it's only considered normal if you have 0 or 1, as long as it's not number 8 or 9. 8 or 9 is always abnormal. But if it's 0 to 1, of 1 through 7, then that is considered normal. Anxiety, there's many forms of anxiety. Panic disorder, social anxiety, eating disorders are a form of anxiety. OCD, obsessive compulsive disorder, is a form of anxiety. Post-traumatic stress disorder, also a form of anxiety. We treat all of these in our programs. They can have multiple phobias. We had a gentleman come to our program from New York City. He lived in Manhattan. Now, the only nice thing about living in Manhattan and our program in California is if you go across the George Washington Bridge in Manhattan, it becomes Interstate 80. And 80 goes from New York City to San Francisco. But 120 miles before you make it to San Francisco, you pull off the exit, and as soon as you're off that exit, you're on the Weimar campus. And he was fearful of flying, so he drove all the way out. Now, because of his high anxiety and phobias, he couldn't come alone, so he had to convince a loved one to come along with him to drive him out there. And that loved one just flew back. You know, it's an easy flight. Sacramento to New York is a lot quicker to go. But he knew he was going to need his car because he knew he wasn't going to get better enough to be able to get rid of his fear of flying. So there can be all sorts of different fears. Substance use disorder is also on the rise. You know, someone was asking us about this yesterday when I was speaking in another venue here in Texas. And when we first started our program 20 years ago, about half of the people that attended had an addiction. You know what it is now? Over 90% of people that come to our program are addicted. And it may not be a substance, but what do you think the most common addiction is today? A substance or a non-substance? Non-substance. And what do you think it is? Yep, it's technology addiction. And the technology addiction and the phone addiction, it can be as a powerful addiction as alcohol. And it can be even as harming as alcohol. And so we have to teach people when they come to our program, the first lecture we give them is about technology now. Why do we do that? Because we're about ready to take away their devices. And they need to know why, and they need to be willing to do that. Just in our last program, we had a young man come there. Well, I say he was a young man. He was 30. Severe mental health issues, 30 years of age. And he gave up his device. He knew about that. But as our staff were looking at things, we realized midnight, this guy's light is still on in his room. And of course, we've been through this before. And so our program director came and said, "We know you have a device in your room. It's time to give it up, or you need to leave." Or we gave him a third option. His mother was also going through the program, but he didn't want to be in the room with his mother. And we said, or you can give up the device and move in with your mother. And so, and he says, well, if I have a device, it kept being if, and it's no, not if. Then finally he says, you know, can I keep it for one more day, one more night? But he told us at the very beginning he was not addicted to any devices. And even then, he was denying he was addicted, even though he was begging to keep it for one more day and one more night. So what does that mean? A lot of people that are addicted don't recognize it. They think that, yeah, maybe I waste some time on here, but I'm not really addicted. And one of the signs of addiction is if your anxiety level goes up when you leave your phone with someone else and you're not going to see it for a day. If that happens, that's a big sign of addiction. And of course, he did give up his devices. He didn't want to leave the program. And he not only had one device, he had an iPad too. So he had an iPad and 2 smartphones, one that he turned in and one that he kept. But do you think he would have gotten better? You know, what was happening is the next day after he was up till midnight or 2 in the morning with his devices, he was sleeping through some crucial presentations on how to improve his mental health. And so doing things that worsen his mental health at night and then not being available to be able to process what will help his mental health. So it'd be a big sabotage to have that around. And then, of course, we teach people how to use the devices smartly. We don't say you have to go without devices for life, but you have to be able to use them smartly. And you have to put some parameters on yourself. So we have to reprogram your phone for you so that you're not wasting time on YouTube and those sorts of things that have actually caused some demise in your brain. So generalized anxiety disorder is indicated by excessive fear or worry about a variety of topics, events, or activities. And it involves 3 of 6 symptoms in addition to the fear or worry. And that is feeling on edge or restless, muscle aches or soreness. A lot of chronic pain is actually caused by anxiety. Easily becoming fatigued or worn out, focus problems, irritability, and difficulty sleeping. So you see why depression and anxiety are related, because some of those symptoms are the same. And most people that come to our program have actually both going on. Depression and anxiety would be bad enough if it just did those things, but unfortunately, it does a lot more. It increases your risk of headaches and migraines, increases your risk of osteoporosis. A depressed identical twin on the same diet will lose 3% more bone mineral density per year when they're depressed. And it has to do with cortisol levels and other things like that. And so osteoporosis, which is a terrible thing to get as you age, can actually be related to your mental health when you were younger. This is why you shouldn't put up with depression and anxiety. You really need to find the underlying cause and get it taken care of. 5 times more likely to abuse drugs or alcohol. Why is that the case? It's self-medicating again. So you're self-medicating, and so this is why if we really want to get rid of substances and addictions, we have to find the mental health issue behind it as to why the person is driven in that direction. Increases your risk of developing asthma, increases stress hormones, increases problems with anger or hostility, increases your chance that your offspring will suffer depression and physical medical problems. And so if you're a depressed mom or dad, you could be causing a depressed child to end up getting more depression. This is why we had a woman in our program in this last program that had 6 children, all under the age of 16. And we knew as a result of helping her, we're helping 6 other children. And what a difference it'll make in their life when their mom is able to be functional and not depressed. And of course, suicide is most often due to depression. Increases your rate of decline in physical abilities with age. Whether you end up in a nursing home or not has more to do with your mental health and physical health. Increases the risk of lack of bladder control. That was an interesting study. In women, if you have depression, you're going to have poorer bladder control as you age. Decreases sex hormones, impairs the immune system, decreases memory. In fact, a lot of memory issues are actually caused by depression. And we've had people misdiagnosed with Alzheimer's. And we found out they had depression. We put them in our program. They couldn't find their room. They had lost their job because of their memory. They had been diagnosed with Alzheimer's. And within 10 days, they're finding their room. We know their memory's coming back. And within 20 weeks, they're hired again, and their memory is great. So a lot of memory problems are due to mental health issues. Decreases your emotional intelligence and social pleasures, and the World Health Organization has stated it's the #1 cause of disability worldwide. People are losing days of work more due to depression in their productive years than any other illness. The medical burden of anxiety. You even have a more marked suppression of the immune system. By the way, I think some of you are telling me you've heard of Chef AJ. She's a popular plant-based chef that has hundreds of thousands of followers. And as some of you know, she's been recently diagnosed with lung cancer. She tells everybody that Dr. Nedley is her doctor, and actually she moved from Southern California to Northern California so I could be her doctor. And she had me on her program just in the last week. I don't know that she's aired that yet. But I was explaining to her anxiety and explaining to her entire audience, anxiety suppresses the immune system. I don't know if you realize during COVID, the #1 comorbidity that would cause death if you got COVID, we probably all know that was hammered into us, obesity. But the second comorbidity that was almost identical to obesity was anxiety. If you had anxiety and you were thin, you could die from COVID because of the suppressed immune system that the anxiety was causing. And it also increases the risk of cancer. If you don't have a good immune system, you're not going to do it, you're going to be more likely to get cancer, and you're going to be more likely to do poorly. So Chef AJ, as a result of that presentation, she says, I'm coming to your next anxiety recovery program. I want to give myself the best odds in regards to this cancer. We even, in the last year, we also treated an 18-year-old with recurrent Hodgkin's lymphoma, cancer. But one of the issues was her anxiety at 18. And so she came to our program. We actually gave her one of the alternative treatments that works very well for lymphoma is fever therapy, IV vitamin C. We had to get the IV vitamin C level up there, but we were also treating the anxiety. She's doing quite well right now. So worsened viral infections, increased risk of cancer, increased risk of suicide, increased risk of self-mutilation, marked increase in the risk of addictions, 80% increased risk of death from physical diseases if you have anxiety, but many times the risk of death from non-physical diseases. What are non-physical diseases? Those are the deaths of despair. Those are, even accidents. Anxiety individuals are much more prone to getting into a fatal accident than people without anxiety. And then social, relational, and emotional intelligence complications also occur. And so one of the myths as well is depression and anxiety is just something you're going to have to manage and put up with your entire life. That is not true. Depression and anxiety can be completely eradicated. And we see that in program after program. People with severe depression and anxiety leaving, and one of the other myths is it will take you months or years before you get better. No, in our program, and even in our community program, some of you saw the statistics this morning in our community program. In our community program, over half of people will no longer be experiencing depression or anxiety in 8 weeks. Just by attending a mental health presentation for 2 hours a week and implementing those principles in their life. Now, over 90% will improve somewhat, but you don't find a therapy on the planet that produces eradication of depression and anxiety at that level. The pharmaceuticals, the best they do in real-world clinical settings is 20% or less. The 20% is kind of the best. Now, they might have a response rate of over 50%, but our response rate in the community program is over 90%. So the response rate of getting better is 90%, 50% will get better in 8 weeks. But the residential program, obviously the residential program, we prefer everyone to try the community program first. But some people are not able to do the community program. You tell them that exercise is good for them, and now are you going to go out and exercise? And some people they won't exercise. They won't change their diet. They won't utilize light. They won't utilize these things that help them out. This is like this woman who was sleeping for 20 hours a day. She couldn't even go to a community program. So this is where the residential program is needed. So if you're not able to do these things on your own with encouragement, that's why we have the residential program. And you will do those things in the residential program. We give you accountability, but it's loving accountability. Our staff or our patients are amazed at, we don't give them spankings, and we don't go out there and threaten them with all sorts of things. But the loving accountability and the setting that they're in encourages them a lot. And what a difference starts happening by day 7, day 8, day 9. And in the residential program, where we can do all the things at the same time, we see a response rate of 98%, and 2/3 will leave without depression or anxiety in 10 days. And so some will need longer. We do keep people there longer if necessary, but what a difference it can make when we get at the root of it. So who is at risk of mental health disorders? There are some people, in fact, interestingly, I won't tell you who this news anchor is that interviewed me a few years ago. But after the interview, he says, Dr. Nedley, I've been through a divorce. My wife has died with a previous marriage. Had all sorts of bad things happen to me. I've never been depressed. And I said, if you have enough hits, you will experience depression. If you have enough blows to the brain. Interestingly, 2 weeks later, he called me up. He said, Dr. Nedley, it hit. And he told me what happened in his life that occurred after that interview. And he had enough hits going on, he had severe depression, and he says, I need your help. And so what does that mean? Anyone can experience depression and anxiety. It's not limited to just people with a genetic defect, although they're more likely to get it. Notice, mental health disorders can influence the lives of anyone, anywhere, irrespective of ethnicity, financial or social status, education level, gender, religion, or personal history. Some are at higher risk based on brain chemistry, lifestyle, or adverse circumstances, such as being a victim of abuse or violence. But learning your risk factors for depression and anxiety can help you overcome these conditions and even protect you from relapse or from ever having any of these diseases in the future. Traditional treatment approaches. Notice this is Nature magazine a few years ago, one of the 5 most prestigious scientific journals. In a study conducted in real-world clinical settings, a common antidepressant, this was seen as the best antidepressant in the market as far as response rate, produced a response in just under half of the participants and achieved full remission in how much? 28%. Once again, this is a lot more expensive. Now, you might not be paying for it, but your insurance company is paying for it. By the way, hopefully America will begin to wake up. But Guam, I told you how we have, those of you this morning, we've written an emotional intelligence curriculum for K through 12. In Guam, if a person does not respond to an antidepressant, one antidepressant, the Guam insurance will not pay for another one until they go through our community program. And the insurance company will pay for the entire community program as long as that person shows up and participates. So, and they have found that this saves them a bundle of money going through just the mental health education with our trained facilitators. And I hope some of you get trained. I understand the Crowley Church used to do this program, but there aren't enough trained people to do it. So hopefully you'll be encouraged to sign up, because you don't have to be a mental health professional to learn how to do this program. You just have to know how to love people and use the parameters that we train you with. And you can be part of changing a person's life and helping them eradicate their mental illness. And so After that, they don't have to pay for the second drug, the third drug, all of those things. And they actually save money over the pharmaceuticals. So this is something that our nation probably needs to figure out as well. Notice back to Nature magazine, 5 decades of work on antidepressant drugs have not made them more likely to lift people out of depression. Medications and psychotherapies help some people with the disease, but do what? Fail many others. And this is why so many people start getting hopeless. I've been on this med, I've been on that med, I've seen this counselor, I've seen that counselor. Nothing's going to work. And I'm just going to have to put up with this for life, and this is a terrible way to live a life. You can imagine why they might start thinking things that they might be better off dead. But what a difference a health education program can make. 8-week community program focuses on the underlying contributing cause of mental health disorders so that a lasting cure can be found. One of the most valuable things is just taking that DAT test to know what hit categories you do have active. It's a 90-question questionnaire, but it is very insightful. And of course, the program is evidence-based, practical interventions, useful tools, supportive volunteer staff, and you also have the group accountability in the 8-week program as well. And the mental health conditions that have been shown in thousands of people to get better are major depression, situational depression, dysthymia, bipolar depression, generalized anxiety disorder, social anxiety or social appearance anxiety, panic disorder, phobias, eating disorders, OCD, PTSD, addiction disorders. In fact, we've even published on some of the most tough to get over addictions like benzos. This program will help you overcome even a benzo addiction. Now, if you're on a large dose, you might need our residential program. In every one of our programs, we have people that are on high dose of benzos. They've been on these for years, or high dose of opioids. We had a woman in our program, this last program, she was on so much opioids that she couldn't get a doctor to prescribe it all for her, so she was buying it off the street, $180 a day habit for years, and now she's on no opioids. Amen. She was on a huge dose, and by day 8 of the program, we gave her her last opioid. Now, she needed to stay an extra week, and she is actually, I have a physician that's helping her right now as well at Weimar, Dr. Arvizu. I understand some of you might know Dr. Arvizu, but Dr. Arvizu is doing our fellowship program, which is a 1-year training program for physicians in depression and anxiety recovery, lifestyle treatments. And she's going to be discharged tomorrow to home on 0 opioids, and guess what? Her pain levels are better than they were when she came on the opioids. Why? Because we've taken care of the underlying issue that was causing her pain or exacerbating it, which was the anxiety part of things. And her anxiety level is better without it. Her depression is better without it. And so when we can find the root cause, what a difference it makes. So transformative change is what this program is designed to do, whether it's the community or the residential program. And you'll also learn the gold standard of psychotherapy. By the way, what is the gold standard of psychotherapy? In fact, even the psychiatric journals call it this. It's called CBT, which stands for what? Cognitive behavioral therapy. Just a little cautionary note sometimes. When you go to a counselor, you might ask them, do you do cognitive behavioral therapy? And they're likely to say yes, because they might have been to a weekend course on it. And so they learned a little bit about it, but it's not what they do on a daily basis. You need to ask your therapist an open-ended question. What is your primary mode of therapy? They can have other modes that can be helpful as well. But what is your what? Primary mode of therapy. If they say cognitive behavioral therapy, chances are they're booked out for at least a year. You're not going to be able to get an appointment because word of mouth is spread that these counselors are actually very good, and you can't get hooked up with them. There aren't enough cognitive behavioral therapists in the nation to be able to help people in regards to their counseling. And so, of course, if you come to our program, we have CBT therapists ready to help, and they also will follow you for 20 weeks to make sure. The whole goal of CBT is so that you become your own therapist, so that you don't need therapy anymore. You understand your own distorted ways of thinking. You're able to correct that on the fly. It takes about 20 sessions. You get equivalent of 10 in our program in 10 days, but you need some work once you go into re-entry to help you with that process. And then we're working on not just the biochemistry of the brain, which is critically important, but also the software of the brain. Now, why do we do that? Interestingly, studies show that when you increase your frustration tolerance, which is getting rid of magnification and minimization, irrational thoughts, when you increase your frustration tolerance and you feel calmer, your brain is able to make more serotonin. We've had individuals come to our program and they say, Dr. Nedley, I'm here for your biochemical help. I know my brain is messed up biochemically, but I don't need to go to your counselors. My problems are real. Well, yes, they have real problems and they have biochemical problems, but if we fix your biochemistry, and the highways of your brain have not been dismantled and changed, we actually won't make you a lot better. It's the combination of the correct biochemistry and the dismantling of irrational thoughts, replacing them with rational thoughts that produce that transformation. So it's a dual approach that's crucially important. So these are some of the results. This is the community program. Those with severe depression at baseline, 94.5% improved at least one category just by showing up and going to a community program for 8 weeks. Try to duplicate that anywhere else, and particularly at that cost, which is pennies on the dollar. Those with moderate depression also improved about 90%. Mild depression also improved and amazing. And notice at the end of 8 weeks, 51.7% that had depression no longer even had it. Anxiety, severe anxiety, 94.2% decreased at least a category. 90% for moderate anxiety, 85% for mild. And notice 57.1%, even higher than depression, no longer had anxiety. The end of the program. We see this also in the residential program. Anxiety is known to be more difficult to treat in traditional clinical settings. It requires higher doses of antidepressants. It requires more side effects, all of these things. But in our program, anxiety is actually easier to treat than depression, which is kind of incredible as well. So it's been shown to help those that have had TBIs. We've had many TBIs, even NFL football players have come through our program. By the way, more common than NFL football players in our program, NFL cheerleaders that have come through our program. And you can imagine eating disorders, body image disorder, and also trauma. Many of them have experienced significant trauma on the hands or at the hands of the NFL players. There's a reason why the ones who hire the cheerleaders said you're not allowed to fraternize with the NFL players. The typical girl thinks that they're being punished, that they can't fraternize with the NFL players. No, it's there for their protection. Head concussions, autoimmune diseases get better. Addictions, chronic infections like Lyme disease, hepatitis C. If you're not exercising at all, the program's shown to be helpful. If you're on a standard American diet or an unhealthy diet, the program will also work. If you've had abuse, adverse childhood experiences, we even did a study on stroke patients. Stroke patients are thought if they experience depression, it's not going to get better. Why? Because that area of the frontal lobe died in the stroke. So we took stroke patients, put them through our program, and we found a 90%, not 98%, but a 90% response rate. So it wasn't as high as if you didn't have a stroke, But yet, we could even produce a response rate in those who had had a stroke. Why? Because we get the rest of the brain working better as a result. Diabetes, sleep disturbance, inflammation, premenstrual dysphoric disorder, or hormonal depression, and more. So what inhibits some from not taking advantage of educational or therapeutic programs? They'll say, is it worth it? It's going to cost money. Well, let's take a look at the money part. Studies have shown that if you don't recover from your depression and anxiety, you will have a $300,000 loss of income over a lifetime. The earlier you get treatment, the better off financially you and your family will be. So a several $100 investment, I don't know exactly how much the community program is. I know we have different prices. Christy, do you want to tell me how much it is that you? Around $100. So we know a lot of places where they're charging $200 for it, but Christy holds it here, charges $100. So for $100, is that worth optimizing your brain and getting rid of depression and anxiety? Absolutely. It's also been shown to improve your emotional intelligence, improve your relationships, and increase your usefulness and employability. I can tell you at the end of the program, the number one regret of those who have gone through the program, and I hear this every program, I wish I would have done this earlier. I wish I would have known about this. I wish I would have gone to it when I was thinking about it. But I'm sure glad I did now. But they realized there were kind of years of life that were wasted as a result. And then, of course, the advantage of developing emotional intelligence that's influenced by a lot of different factors. But what you think can be improved upon. And when that happens, improve relationships and all kinds of relationships, work relationships, family relationships, more effective work productivity, which often results in greater employment and wage opportunities. And of course, if you don't have the number one cause of disability, depression, you're much likely to be at work every day. Increase in healthy motivation will also result in greater accomplishments. So I would encourage all of you to become a part of, at least in maybe putting on the program or going to one in regards to the connection, support, and availability of either the community program or the residential program. I think I mentioned this 98% response rate in the residential program, and this is the Beck Depression Inventory, 68.4% complete eradication of depression in 10 days. Now, it's more than that if you stay 17 days, and some aren't ready for reentry, so they need to stay 17 days. In fact, we're actually doing, one of our students is actually doing the research in regards to compiling the program completion data. And program completion data is not just where they're at in 10 days. If they need 17 days, then it will be the 17 days, where it is at completion. Now, we've already done a study in regards to 20 weeks. So these results are maintained at 20 weeks. They're ready for reentry. They don't relapse. They've noticed the benefit. They continue on the things that will make them better. And notice the EQ score goes up over 20 points. That's 2 standard deviations to the top 20 percentile of the nation and the average person leaving the depression recovery program. How do we get more serotonin made? A lot of it has to do with diet and lifestyle things. Notice this. This is a review article by Lancet Psychiatry. It's a European psychiatric journal that reviewed a lot of the things on diet and depression, and they said diet is as important to psychiatry as it is to cardiology, gastroenterology, and endocrinology. Now is the time for the recognition of the importance of what? Nutrition and what else? nutrient supplementation in psychiatry. If your psychiatrist is not asking you about your diet, is not talking to you about nutrition or nutrient supplementation, he is no longer mainstream. He's old school. Because notice this next statement: nutritional medicine should now be considered as a what? Mainstream element of psychiatric practice. That's where we can fix the underlying defect and we don't have to be plugging reuptake channels. By the way, if you've plugged reuptake channels, there's hope. Don't think that, yeah, it would be better if you came to us before you got on medicine, but within 20 weeks, 90% of our people are depression-free, anxiety-free, and medication-free. Some are still going to need medicine because of what's happened to them earlier. So our goal is depression-free, anxiety-free. It's not necessarily medication-free. But whatever it takes to eradicate depression and anxiety, a major part of it is going to do with the nutritional medicine and looking at your genetics and those sorts of things that can be helpful. These are studies that are, the studies that have been published on this program shows it to be the most scientifically studied program for depression and anxiety worldwide. There's actually more data on this program than there is on any medication released by the FDA to treat depression and anxiety. They'll release it with 400 patients taking it. And these are tens of thousands. Highest N value, the most effective low-cost approach to depression and anxiety. And notice, these are the kind of things that we mentioned. These are all things that have been shown to still produce a positive result, no matter what that background. So, of course, there's personalized aspect depending on what hits are there for you as well. It's not a one-size-fits-all. And you, of course, you get the program material. So with that $100, you're actually getting some good material that you can take home with you and continue to read and support as well. So each one of you are more than a statistic. I've been talking to you a lot about statistics tonight. But you are a deeply valuable individual with a story to tell and a future to explore. While your journey is unique, you're also not alone. As you've noticed, depression and anxiety is everywhere today. And around you are countless individuals who can resonate with your emotions and are unsure what hope, happiness, or recovery might look like. But there is hope. And hope is not passing you by. Bad things probably happened in your life. I can get that. But this is where you decide to continue to live your life the way you are now and hoping for a different result or getting to the root of the issue. And I think recovery is for you if you have any of these mental illnesses. So I would encourage you to allow my team that we've trained for the facilitators and associate directors or the team in our residential program to give you the keys to transforming change and support as you invest in your own future and story. These are some of the references of what we have talked about tonight. If you want to look at that, by the way, the Journal of Lifestyle Medicine has published in regards to these over 100 causes that we found, and that is one of the references there as well. But also, we've been asked to write the textbook portion of the American College of Lifestyle Medicine textbook. There's a lot of people that are now board certified in lifestyle medicine, and to get board certified, you have to read the mental health section that they had me write, as well as prepare for the board reviews. So more of this information is starting to get out there, which we're happy about. But I would also encourage, if you know a physician that would like to dedicate their life to helping changing lives on that, we do have a fellowship program as well, and let them know about getting us. It's a paid fellowship program. You don't go there for free. You get paid, and you get to learn as well in regards to those treatments. So any questions at all about what I have presented? I know it's been kind of a broad brush. Also, we have, my son Nathan is in the back. We have a table there with some of our things that people have found useful in regards to their mental health there as well. You may want to look at that. But just some questions, and I don't know if we have a roving microphone, or maybe I can just repeat it if we can't find a roving microphone to take it around. Yes? Yes, so we've had many individuals come to us who have been on ketamine therapy. Ketamine is actually works somewhat like a psychedelic in regards to short-term benefits for depression and anxiety. But there is a ketamine clinic that's probably the most busy ketamine clinic in Oregon, and we have patients from their clinic every month because when they fail ketamine, they refer them to us. And so, but the issue with ketamine is you have to continue it. And it's not just a one and done situation. And so there's relapses, and they're not really taking care of the underlying defect. It's just taking care of some of the symptom aspect of things. So we haven't had anyone need ketamine after they come to our program. And fortunately, that ketamine clinic is wise to tell them, all right, we've done 25 treatments. Maybe you ought to go down there to the Nedley program because you're going to continue to need this. And of course, it doesn't work as well either. The longer you go, it doesn't produce the response that it might have initially done. Yes, question.
Although, like, instead of all the,
Nobody else can hear.
Okay, Alpha Stim is a product or device by using like any of those SSR, whatever, antidepressants. Is that, well, what I want to know, like she mentioned ketamine therapy, is it more of a placebo or is that effective?
Well, ketamine is better than a placebo.
No,
yeah.
I'm not, I was meaning as in the effect of Alpha Stim. It's
Oh, okay.
the electro.
Yes, and there's also something, there's different ways of stimulating the brain. There's also something called TMS. Of course, the major way of stimulating the brain is ECT, electroconvulsive therapy, where you actually induce seizures. And ECT does help depression. It doesn't have the rates of improvement that we have, but it still has much higher rates of improvement than with medicine because of that whole seizure stimulation side of things. But there are serious effects of it. And by the way, the 30-year-old that had a device problem, he had been through 20 ECT treatments before he came there. And there were memory gaps in him, significant memory gaps that occurred as a result of the ECT. So we have to look at the benefits versus risks. We like to utilize approaches that have benefits with zero risks, if at all possible. And so TMS has some risks as well. It's not as risky as ECT, the transcranial magnetic stimulation. But again, short-term results. ECT is not going to be long-term results either. And the Alpha Stim, probably better than placebo, but once again, it's not going to be taking care of the root of the issue. And so a relapse is going to be quite likely utilizing those techniques. Yes?
What are your thoughts on EMDR?
Yeah, so EMDR is a form of therapy that's gaining a lot in popularity. If you want to see what I believe in EMDR, now Wikipedia is not good for a lot of different things, but Wikipedia actually has a pretty accurate analysis of EMDR. And it goes through all of the studies in regards to EMDR. What I can tell you with this is when people that have gone through our residential program have not needed EMDR. Many have had EMDR before they come there. And EMDR is not the same as CBT. Some people will say they need EMDR in order to be able to try to get the person to do CBT. By the way, the gold standard of psychotherapy, let me just tell you this, the gold standard of psychotherapy is not EMDR, it's CBT. But CBT only works 57% of the time as far as a response rate. Why is it so poor and it's the gold standard? Because other things are far less as far as a response rate. And so, but why do we get 98%? We do CBT in our program. We think it's a vital part of the program. we are doing things to enhance their frontal lobe so that they can grasp CBT. Some people don't have enough frontal lobe function to even begin to analyze their own thoughts. They just go into negative automatic thoughts all the time. And so we want their frontal lobe to be enhanced enough to be able to understand the concepts of CBT to start to get that software better. And EMDR, when we take a look at it, is not quite as good as becoming physically fit is for your brain is concerned. And so we want to get to the core issues. But once again, I'm not going to blanketly criticize EMDR. I'm just going to say when you're dealing with things how we have and we see those type of responses, we haven't had to do EMDR in order to get those responses. All right, so anyone else?
I actually have two questions, if that's okay. So one, I know you said diet-wise to take care of your diet. I'm wondering if you've noticed any correlation with mental issues and food dyes, high fructose corn syrup, things like that.
Yeah, absolutely. Yeah, there can be mental health issues. High fructose corn syrup, by the way, is one of the things that can drive ADHD. And so one of the first things we do in regards to ADHD is taking away the high fructose corn syrup and even the sugar substitutes. Now, some people will say there's something in regards to the actual sweet taste that brings about ADHD, whether it is high fructose corn syrup or whether it is an artificial sweetener like aspartame. It can do the same types of things. And so, yes, and of course red dye. People that are more sensitive to those type of foods normally are over-methylators. There's a genetic tendency to have that sensitivity. And so once we treat the over-methylation, then all of a sudden they can have all sorts of foods that they thought they were sensitive to before. But red dye isn't really helping anyone. And I saw that, I think, on our new health officials list to try to get rid of because of the issues that have come about in regards to red dye. So we don't recommend that for anybody. But there are some people that have sensitivities to even healthy foods. And often that's due to over-methylation. And when we treat the over-methylation, they can eat the healthy foods again. So of course, that's a great joy when we discover that and can get them on the right pathway there. Any other questions?
I have a second question.
Okay, someone raise their hand so I know who I'm looking at.
It's
right
me
here.
still.
Okay, good.
So you also mentioned something about supplements. Is there certain supplements that you recommend?
So yes, there are certain supplements for particularly genetic conditions or maybe short-term supplements. Vitamin B12. Did I mention B12 this morning? I don't think I did. That was in the other conference. Vitamin B12 helps us make 3 different neurotransmitters: serotonin, norepinephrine, and dopamine. And if you're short in B12, you can feel great within 3 days of getting enough B12. And so vitamin B12 is actually not a problem with your diet because it's not in animal food. I mean, it's not in animals and it's not in plants. B12 we get from healthy bacteria. And it's the only nutrient we absorb right next to our colon, because our colon is our microbiome, and there's quite a connection between the gut and the brain and the microbiome. This is an area where we're actually researching. We did studies on people, even in our program, pre and post microbiome. We have a biochemist in Canada that we're working with that's publishing all sorts of information. Our diets actually help your microbiome. And when you have a B12 deficiency, it wasn't because of your diet, it's because of your microbiome. And so, but supplementing with B12 short term can be helpful, and then we're going to try to help your microbiome so that you don't necessarily need to take B12 supplements for life. And so some things are short term, maybe a folate deficiency, maybe a magnesium deficiency. Those sorts of things would be short term, but what would be long term? This is where you have a genetic issue called undermethylation. Undermethylators are calm exteriors and tense interiors. They're highly competitive, they can be high achievers, high tendencies to addictions, and then they ruminate. Things happen and they'll think about it over and over again. And then we'll do a blood test. We'll find out they're an undermethylator. And what can fix them is a supplement. It's a dual supplement that we put together, S-adenosylmethionine with saffron. Those two combined can fix undermethylators if they're given the appropriate amount. So we formulated that in a one called Mood. And you also tend to have more obsessions. If your tendency for OCD, that can also be undermethylators. So we've had individuals come, they're doing great, their OCD's gone, they're doing everything well, and they think, okay, I think I can give up this Mood. It takes it a while, takes it about a month, but now all of a sudden they're right back into it again with all the distorted ways of thinking that they were doing before. And then once they get back on the Mood, it'll take them at least another month to get better. And so they'll realize, I'm not getting off of that. That was the primary fix. And they don't need to keep increasing it like a pharmaceutical. Every year it's having to go up. If anything, we can actually do their tests every year and maybe decrease it some. But that's something that they might need to be on for life. So that's why the Psychiatric Journal is talking about nutrient supplementation being mainstream. Another one might be a pyrrole disorder. This is where you have the ADHD symptoms, poor stress control. You have a tendency to be a nighttime person. You don't want to eat breakfast. You have, normally irrational fears, those with phobias, with irrational fears. That fear of flying individual, he had a pyrrole disorder. And so for that, we'll add a supplement called Brain, and then we'll add NAC, an antioxidant called N-acetylcysteine. We'll be able to bring those pyrroles down to normal, but if he gets off of those, he's going to start thinking some irrational thoughts. We've had people we had a doctor come to our program that was fearful of going over bridges, and he lived in Northern California. You know, there's bridges everywhere in Northern California. He'd go an hour out of his way to get to work so he wouldn't have to go over a bridge because of this phobia of bridges. And so that requires some nutrient supplementation in addition to the CBT to be able to help them with the irrational fear that's associated with that. And of course, there's a lot of other genetic issues. I've just touched on a couple of them. For the ADHD ones, the supplement Focus is great. Focus, by the way, there's 4 nutrients in there, Bacopa monieri, which has actually been shown in ADHD people not only to improve focus, but to improve personal control. They're able to manage their emotions, and they'll notice a difference. We have an ADHD individual I was just talking to the other day, a college student. He said, within 90 minutes of taking this, I can control myself. And he said, I can focus. It's pretty amazing. We have Bacopa monieri, and then we have memophenol, which is actually from a wild blueberry extract with a wild grape extract, which is a very potent antioxidant that goes to the memory portions of the brain. And then we have the raw ingredient that's needed to make acetylcholine, which can also help us. With those 3 plus N-acetyl-L-tyrosine, L-tyrosine turns into dopamine and norepinephrine, very important for focus and our memory. With those 4 things combined, the studies are showing some amazing results. Even if you've started to lose your memory, taking that just twice a day has been shown to improve your memory to the way it was 10 years earlier in your life. And so we're getting some gratifying results of that. And so someone with ADHD who has the genetic mindset, they might need to take Focus. Yes?
You mentioned the 90 question instrument.
Yes.
How does somebody get access to that?
Yes, it's called the Depression and Anxiety Assessment Test. You can actually take it online. It will cost you more than going to Christy's program, though, and she'll give you 2 of those tests, one before and one after. But online, it's $109. Depression and Anxiety Assessment Test will give you a 25 or 30-page report if you take it in regards to whether you have depression, what your emotional intelligence is, whether you have anxiety, or how much you have, and then the hit categories that were discovered as a result of the test that you could do differently to help yourself out. So even taking that test can be valuable. And so if you look up DAT test, you'll be able to find it online. Yes?
One of the books that helped me understand what neuroplasticity is called Switch on Your Brain by Dr. Carolyn Leaf, I believe. I really love that book, and I want to learn more about it. Do you have any suggestions on any other books along those lines?
Yeah, there are some great neuroplasticity books. Barbara Arrowsmith Young, she is a neuroscientist in Toronto, Canada, that's particularly worked with learning disabilities, where people think they have learning disabilities for life. She had a learning disability, and she discovered how to be able to help herself through the process, and then ended up becoming a neuroscientist. But she was a 12-year-old and couldn't even tell time on a clock, you know, a hand clock. That's how severe her learning disability was. But if you can get some of her material, it's good. And then there's things that turn on the positive neuroplasticity switches. One of the things that will help your brain change better, if you're set up for it, we don't do this for everyone, but when they come through our program, if they're able to handle this, we will actually put them on a fast. A 24-hour fast will increase their brain-derived neurotrophic factor and turn on the positive neuroplasticity switches so that they'll be able to change much quicker and have that brain ready for some very positive changes. And one of the things that can keep the BDNF going on is what we call intermittent fasting. There's been a lot of studies on intermittent fasting as well. But yeah, neuroplasticity is based on what our program is all about. Our program would not work if the brain was not able to change. And so we're utilizing all of the research behind neuroplasticity to get these brains to change. But thank you for that question. Yes.
Dr. Nedley, I was just wondering if you could tell us a little bit about the EQ Summit.
Oh yes, thank you. So the Emotional Intelligence Summit is something that we hold every year. We used to hold it in Dallas, Texas, and it was pretty easy to go to. So I think the first, maybe the first 7 years was held in Dallas, but that's when we lived in Ardmore, Oklahoma, so it was close by. But now we hold it at Weimar University during spring break, March 13 through 16. I don't know if Nathan's back there. I don't see him there for the moment, but pick up a brochure about that. We have some great speakers coming, in fact, more speakers than ever before. If you're a physician, you get 24 hours of continuing medical education credits. If you're a nurse or a counselor, you also get CME, continuing medical education. Or if you just want to learn more about emotional intelligence, we're particularly looking at the relationship aspect this year. So our relationships, if we're having any issues with our relationships, you can get those often fixed as a result of enhancing your own emotional intelligence. And so whether it's a workplace relationship, a family relationship, issues between mothers and children or fathers and children, or any type of relationship, maybe relationships that have ended. We have a whole expert coming. What if the relationships have terminated? How do you then improve your emotional intelligence after that? And so, and then a lot of the things that affect that, like brain chemistry issues that we're going to be doing. One of the talks, I'll tell you about, one of the talks that will be worth the price of admission is Dr. Brian Mears. I was telling someone about him this morning. Brian Mears was a nurse anesthetist. His wife was a nurse anesthetist. He was actually president of the National Nurse Anesthesia Association. Was all for nurse anesthesia. And by the way, do nurse anesthesia people make good money? Oh yeah, they make good money. And if his wife was there, they couldn't have any children though. And his wife's sister had 7 children. They were all out of wedlock. She was an addictive gambler. She was in Las Vegas with 2-year-olds all the way up to age 15. 7 kids in a van while she's in there gambling. And one of them, the 7 or 8-year-old, called up Dr. Brian Mears, the uncle. Dr. Brian, will you take us? Will you take us and raise us? And went through all of those issues. He said he knew he was going to get a call someday about that. And he said he would take it on one condition, and that is that he was able to be the full adoptive father and his wife the full adoptive mother. So he adopted within 30 days 7 kids, 15 and under, all with serious mental health problems. And so he started putting him into the mental health system. He was from Little Rock, Arkansas. So he started him going to the mental health system, and he found out the good mental health providers were hard to get into, but the mental health providers didn't communicate with the other ones, and they were just doing patch job types of things, and it was very frustrating. He's having these kids, and he can't get them better because they all have serious mental health issues. And so he decided, you know what, I'm going to become a mental health professional. He went to the University of Cincinnati because he was such an advance. He already had his doctorate in nursing. They had a 1-year program to become a doctorate of nurse practitioner, psychiatric nurse practitioner. He became a psychiatric nurse practitioner. He learned about what we were doing. He's actually been and shadowed our program. And he is now utilizing that in Arkansas, and over the last 6 years of him starting his first clinic, he now has 40% of all the mental health clinics in Arkansas. And he is changing Arkansas mental health based on how he was able to start a outpatient psychiatric clinic utilizing tools that are really going to get at the root of issues. And a lot of it has to do with relationships. It's not only knowing what to do, you need to know how to hire people. You need to how to have them work together. You need to know how to educate them. And so it'll be worth the price of admission just to hear his talk and then his breakout session in regards to all of this. And so I have a lot of hope for psychiatry today. I do think it's going to change. It has changed dramatically in Arkansas. I gave him his next challenge, though. I said, I want you to start a psychiatric hospital that totally does things to get at the core of issue and not just medicating people and not just doing safety plans. And by the way, he has 30 nurse practitioners that work for him. He has 3 psychiatrists that work for him in Arkansas. He has all sorts of cognitive behavioral therapists that work for him as well, although he says that's the hardest to find. And you know one of the things he does for a secret? He hires our 1-semester trained health evangelism and leadership training graduates from Weimar University. They don't even have to go there. They just go to the psychiatric clinic visit by phone. And they'll say, this lifestyle measure can help. That can help. And the psychiatrist will say, okay, you need 2 more visits with the health coach in order to do this. And so that health coach is actually earning very good money helping people get to the core of issues because of what they learned at Weimar University. And they can help encourage them through that whole process. They know how to encourage them through that process. And it doesn't take away the psychiatrist's time for what medicine are we going to take you off of now, or how are we going to wean you off and all of that, because there's a health coach that's there part of that whole visit. So that's one of many speakers. Go look at it in regards to March 13 to 16, and we'd love to see you at Weimar University where we run our program. All right, we might have time for one more, and then we probably should break, and I'll be out in the back if anyone has any individual questions.
It's just about the B12. I wanted to find out about the methylcobalamin and the cytocobalamin, which one you would recommend.
Okay. Yeah, there's 3 different types of B12 supplements that you can take. You named 2 of them. There's a third one called hydroxycobalamin. That's our actually preferred one because hydroxycobalamin is a cyanide scavenger, and it actually can absorb toxins. If you were to go to the ER with cyanide poisoning, they'd give you IV hydroxycobalamin. And cyanocobalamin has the cyanide molecule already in it. And as a result, if your B12 level is too high from cyanocobalamin, it's been shown to increase your risk of cancer. Cyanide is a toxin. So cyanocobalamin is the cheapest way. If you're taking a vitamin B supplement, chances are it has cyanocobalamin in it. We recommend methylcobalamin or hydroxycobalamin because you don't get the cyanide that way. We would only recommend methylcobalamin if you're an undermethylator. So if you had some of those symptoms that I just talked about and you were low in B12, we would give you methylcobalamin. But if you're not an undermethylator, we recommend hydroxycobalamin. And of course, anyone can take hydroxy. It's best chewed. You can absorb it sublingually. And that's a great way to get your B12 level up. And people will notice a significant difference taking the hydroxy because it's having more than just the B12 effect. It's also a toxin scavenger. All right, well, you've been a very attentive group here tonight. I sure hope this was helpful to you and maybe helpful to your loved ones, that you can tell about what you learned here tonight. And why don't we close with a word of prayer before we depart. Father in heaven, we thank you that you are interested in every human being. You love us with an unfailing love, and you desire for us to have our brains optimized. And we pray, Lord, that we would not only learn what we learned tonight, but also incorporate this information in our own lives so that we might experience a more abundant way of living and be able to represent you better. In Jesus' name we pray. Amen.
Thank you, Dr. Nedley. It's been a pleasure hearing all of this. And what an amazing God who designed such a brain that can heal and recover. And we're just so special that we get to have that in each one of us, and we're all made special. There is a table over in this corner with some healthy snacks for you, so please enjoy and mingle, and thank you for coming.
I'm so glad that you've joined us at the Crowley Seventh-day Adventist Church. My name is Adam Keating, and I am the senior pastor here at this wonderful church. We're so grateful that you had the opportunity to engage with us online, and we pray that the things that you saw and the things that you heard were uplifting to you. We believe that God uses His Word to be a blessing to His people. We would love to be able to talk with you, to pray with you. If your next step desire is to study God's Word, we'd love to be able to study with you as well. Please give us a call at the church at 817-297-7737. Again, we would love the opportunity just to visit with you and see what God is doing in your life and how we as a church, or I as a pastor, can help take you to that place where God longs for you to be. Again, we pray that you received a blessing from this church service, and as you go throughout this week, may you go with God's grace and God's blessing.